Hi, everybody. This is um, the Psychiatry Network Facebook Live Journal Club. And this is our last journal club for, I guess, the season and for the project that we started. So tonight we are going to have Dr. Lisette Rodriguez-Cabeza right now. And she will be presenting our article tonight. Hi there.
Hi.
How are you?
Good. How is everything going tonight?
Good.
Good.
Yeah, I can hear you well, like your audio is good and everything. So,
Perfect.
um, yeah, so I was just mentioning this is our last journal club for this project that we're doing. And so this is our 42nd video. And Lisette and I actually know each other from work. So she works in my department. So it's always nice to have somebody I know on the videos. And we were scheduled, I think, a few weeks ago, but had to reschedule because my son was sick. And I was like, it was not going to happen that night. So, yeah, and I appreciate her time tonight too, because I know she also has two kids. So, okay, so let me tell you guys about her bio, and then we'll get started. So Dr. Rodriguez-Cabezas completed her residency and women's mental health fellowship at Northwestern University here in Chicago, Illinois. She currently works at Hines VA, just outside of Chicago, Illinois. She works in the mental health clinic, seeing men and women veterans, and also works in the women's health clinic, specializing in mental illnesses spanning the entire female reproductive cycle. She's not currently doing any research, but she has published a review on perinatal psychiatry, which I think we posted it in the group around the time it was published, and people found it really helpful. She went into psychiatry because it was her favorite clerkship. She loved the luxury of the amount of time we get to spend with our patients. She also finds psychopathology fascinating, and there's never a dull moment in her work. She enjoys helping patients find hope again and loves working with pregnant and postpartum women. And so with that, we will get started on
Awesome.
our
Thanks.
topic. Yeah.
Thanks for picking this article. I think it's a really good one. A lot of good talking points in it.
Yeah.
So with that, I will start. So this article is called "A Woman with Major Depression with Psychotic Features Requesting a Termination of Pregnancy." So basically, we'll go through the case discussion, talk about the relevant facts of the case, what happened, and then go through a discussion about basically some things about capacity, how do you make that determination when there are lots of things to consider, especially when you think about abortion, which is kind of a hot topic right now. So we'll go through that. And so starting with the case, this is about Miss A, who's married, pregnant, she's 31 years old, has a history of major depressive disorder, and she was admitted to an inpatient psychiatric unit complaining of dysphoria, ruminative worries about her work performance, trouble sleeping, doubts about being a good enough mother, and then suicidal impulses to jump out of her apartment window. On the day before she was admitted, she actually impulsively punched herself in the stomach in the hope of inducing a miscarriage. So at that time, her outpatient psychiatrist advised her husband to bring her to the hospital. So Miss A had no previous history of psychiatric hospitalization, no prior suicide attempts, no self-injury, no history of drug or alcohol use, or any manic symptoms. She had no real legal access to lethal means to take her life, but she did reside in a high floor of an apartment tower, so her impulses to jump out of the window would have likely resulted in her death. She didn't have any medical problems. Her mother did have a history of major depressive disorder and had been well controlled with paroxetine, but there was no family history of suicide. She was a foreign national but spoke English fluently, and her husband was a compatriot and a grad student. Her pregnancy was planned, which I think is really important to note. She was under, obviously, the supervision of the outpatient psychiatrist. That doctor was the one who referred her to the hospital. Under their work together, or in their work together, she had decided to discontinue venlafaxine prior to conception because of concerns of teratogenicity, which is not an uncommon scenario. 3 months after she discontinued, she was promoted to senior role at her law firm, and she was assigned to more complex cases. That's when she started experiencing anxiety and worries about being able to do the job effectively. She had difficulty concentrating, insomnia, ruminative worries, thinking that she might be fired, and then just kind of catastrophizing, thinking she might lose her visa, ultimately not being able to support her husband or her child financially. She then developed some delusions in addition to that, that her colleagues were recording her conversations, collecting evidence to justify her termination from the job. And then, so for this, her outpatient psychiatrist restarted the venlafaxine at 75 milligrams per day, and then also initiated olanzapine at 5 milligrams per day. This was a month before her admission to the inpatient unit. By the time she was admitted, she was grossly dysphoric, preoccupied with the ruminative worries about the cost of hospitalization. She had ongoing suicidal ideation, and she was put on one-to-one status because of her just suicidal ideation, how severe it was. She requested a consultation with an obstetrician to facilitate a termination of pregnancy. So obviously very concerning in the context of all the symptoms that she had going on. She was not really making a whole lot of sense with her rationale. She was comparing the relative cost of the abortion to the ongoing psychiatric hospitalization. So she also had a delusional certainty that her fetus was harmed by her taking psychiatric medication, which was delusional. There was no evidence to support that. Two psychiatrists felt that Ms. A lacked capacity to consent to a termination of pregnancy when she was admitted. She was at 22 weeks and 6 days at that time, and abortion is legal in New York until 24 weeks. So clearly there was a urgency to try to make the determination, did she have capacity or not, because she only had what was like 8 days to basically make that cutoff of 24 weeks. So her husband was her next of kin. He was ambivalent about her desire for an abortion, but said that he wanted to be supportive of her. She declined ECT, but accepted medication. Her treating psychiatrist felt that she had capacity to at least make the decision to accept medication. Given its prior benefit, she was restarted on the venlafaxine at 300 milligrams a day. Olanzapine was increased up to 15 milligrams per day. OB was consulted to counsel the patient. The OB team gave the inpatient psych team a 5-day window to treat the patient and make a final capacity determination regarding her request for an abortion. So, and also the ethics committee was involved just to give some additional guidance to the inpatient psych service. The legal affairs department was also consulted to help determine whether Ms. A's husband, the surrogate, could give surrogate consent or not, if she still desired a termination but continued to lack capacity. So on the 5th day of hospitalization, the same two attending psychiatrists reevaluated the patient, and over the preceding 5 days, she was just, you can tell she was improving. She was engaging with the milieu much more. She was starting to accept their kind of, I guess, recommendation or their advice that she should think twice about terminating her pregnancy, and she felt encouraged to go ahead and continue the pregnancy. She did have some ambivalence about that prior request for termination, and then an ultrasound that the OB team did show that there was no evidence of congenital malformations, which helped her to be less fixated on the potential teratogenic effects of her medication. She was able to fully understand the risks and benefits of the proposed abortion procedure. Like, she could say exactly what the abortion would involve. It was a potassium chloride injection followed by an evacuation and curettage. Both psychiatrists felt that she had capacity to consent to an abortion at that point, after she was able to understand all the relevant facts and able to make a decision. However, after additional discussion with her husband, her family, and the OB service, she actually decided to not pursue the abortion. After additional inpatient treatment, she was discharged and went back to work. She was admitted to the OB service 3 months later at full term, delivered a healthy male infant. She was euthymic at that time and in the postpartum period. After she had her son, she continued the venlafaxine and olanzapine with luckily sustained remission of her depressive symptoms, and she was looking forward to spending time with her son on maternity leave. So really she had complete resolution following that treatment that she got inpatient, which is the good news. So that's the case. And just to start the discussion, I think it's important to talk about what circumstances require with formal capacity assessment. In this case, they had to make that determination, did she have capacity? They also, what was important is making sure that they were treating her depressive symptoms, as that could definitely have an impact on her ability to have capacity. And they also, had to identify a potential surrogate and figure out how they would potentially go about using that surrogate if that was in fact needed. So just to review capacity, which I think we probably all know really well, but the steps that really are important with determining capacity is, being able to communicate, and I add this part in, a consistent choice. So, it says in this review or in this article that it's just communicating a choice, but I think the consistency part is really important too. And then understanding the relevant information. So can they, have a good appreciation and understanding of what's involved in the decision-making process, appreciating the situation, all the consequences. So if she were to go about with the abortion, what are the consequences of that? If she decided to go against the abortion, what are the consequences of that? And being able to understand all the different scenarios that are possible. And then finally, being able to manipulate the information rationally. So, I think there's some good evidence that at some point early on, before she was actually treated, especially with the delusion, she wasn't able to really manipulate the information rationally. I think a good example of that is balancing, the cost of an abortion versus the cost of continued hospitalization. Like, that doesn't really show that she was really appreciating the gravity of what the abortion would actually do. So in this article, they go on to say that, the criteria, the ones that I just mentioned, are broad and they have to be tailored to the unique circumstances of the patient, which I think is an important point, especially because in situations such as an abortion, which is a huge decision in someone's life, there is some degree of ambivalence a lot of times. So, being able to communicate a consistent choice, they may waver. There may be moments when, yes, they want to go ahead, and then moments when they talk to family or they talk to friends and they're like, you know what, I'm not sure. So, especially the more complicated the decisions get, I think the more ambivalence it's likely to occur. But you want to see, can they, for the most part, have some kind of rationale or some kind of criteria that they're sticking with, and that they're kind of continuing to use that logic throughout. And then also you want to think about what were their premorbid wishes. So in this case, we know, which is, I think, makes this case a little easier than maybe if we hadn't had that information. We know this was a planned pregnancy. If this was an accidental pregnancy or unplanned, then it might be a little bit harder to determine, did she really want, this abortion beforehand or not? So I think that helps in this case. And let's see. So any irrational conclusions about the future, like especially in this case, she was having a lot of depressive symptoms that seemed to really affect her ability to make the decision, which were things like pessimism, feeling worthless, not being able to really appreciate her ability to care for the child in the so she wasn't really thinking that she would have what it takes to be a good mom. Will that always be present? Likely not if her depression was treated. So, if that's factoring into her decision to go ahead with the abortion, that may not be the most useful information to make that determination or make that decision for the patient. And also, obviously, if there's any delusional content, so this wasn't mentioned in this particular case, but a good example is if a patient is thinking that the fetus is an alien, that clearly is not really something that you can use as a criterion that they're thinking rationally. She did think that the child was malformed, which was not supported by evidence. So that is delusional, for this patient in particular. So once you saw that she was treated, and she was given the information of an ultrasound, she did actually come around and say, you know what, I think this baby might actually be okay. And that delusion kind of cleared up at that point. There's an additional criteria that one of these authors that they cite was included in this article. So for the depressed pregnant patient, they wanted to also consider, or have whoever's evaluating her decide if the patient can appreciate the gravity of the decision. Basically, if it's something like an abortion, this should be appreciated as something very significant in her life. Like, this isn't just deciding, what clothes you're going to put on today. This is, a decision that's going to definitely have a major impact on the future course of your life. So if they can't appreciate that this is a much bigger decision than something that's more mundane, then that should probably weigh into how the capacity is determined as well. So, for example, when she was comparing, the cost of the hospitalization versus the cost of the abortion, again, not really appreciating that this is probably a lot more important than just, finances. So, so in trying to see patients like this, a good way to help with capacity, or to help restore, or actually the main goal should always be trying to restore capacity if you can. If you determine initially, which in this case they did, that she didn't have capacity to make the determination about abortion, then you should always try to restore capacity if you can. So they had a time frame in which to do it because of that abortion rule of 24 weeks. So they had 5 days, which is not a lot of time, to go ahead and try to restore capacity for her. So what they did was they provided evidence-based treatments, which is obviously what we always try to do. So those include psychotropic medication, ECT, which she actually refused, psychotherapeutic modalities, which one would assume she received on the inpatient unit to some extent. But she definitely got the psychotropic medication. And, I'm sure psychoeducation was provided for the family. I would imagine that was included as well, even though it's not specifically mentioned. So, and I think this is a really interesting and a really good point too, is that they recommend that the psychiatrist who does the final determination of capacity be somebody other than the treating psychiatrist. Because if you plan on, seeing and treating that patient in the future, you don't want that to be a reason why there's not a good therapeutic alliance there. So I thought that was a really good point. If you have the ability to have an outside person do that final capacity determination, I think that would really help in the long run. So always, another recommendation they make is to try to have the patient have the most, autonomy and ability to make their decisions if it's possible. But if that's not possible, if you can't restore capacity, then you want to find a reasonable surrogate. And in this case, really kind of the only one we have is the husband. There's really not much other family mentioned. So that was easy. He was the automatic surrogate. But it's important to note, and I'm not sure what it's like in Illinois, but in this article, it specifically states that consent statutes vary by state. So in cases like abortion specifically, they may not allow a surrogate to make the decision for the patient. So I think that if you have a similar scenario occurring in your state, you might need to look up the local laws to see what you do in such a case, or maybe just get your legal affairs department involved to find out what you can do in those cases. So that might be extra tricky. And then So when you do have a surrogate decision maker, that person doesn't just make the decision. They don't, look at the case and say, hey, this is what I think the patient should do. Really, their role is to, and I think we may already know this, especially you, Christina, because you do CL psychiatry, but if a surrogate is having to do this to make the decision for the patient, they really should go by what they think the patient would have wanted. If they knew, so for example, the husband in this case knew that the pregnancy was planned, then his decision should be, no, do not go ahead with the abortion because she wanted this baby. But if it's not known, then, kind of knowing that patient and thinking about their values, thinking about what kind of person they are, they should try their best to think about what the patient would have wanted, what they would have done had they had capacity in that moment. And then if that's not known, then they should always use the patient's best interest. So, what's going to be most helpful for the patient in the long run. So that's kind of the hierarchy with which the surrogates should really go by when they're trying to make these decisions. So obviously there's a lot of ethical implications with cases like these. Psychiatrists are trying to be beneficent and trying to do what's best for the patient and try to preserve the patient's autonomy as best as possible. And a lot of people think that, if you can have that really useful information, knowing what a patient would have wanted before they became ill, that's probably the best way to determine if what they're saying in those moments, if that's really, it argues for capacity, if they're going towards that same line of thinking. So that line of thinking is called preventive ethics, and that's what this paper is talking about. Being able to kind of reflect their decisions are reflecting their more authentic beliefs that were premorbid. So, but you also have to think about, is that muddied by their depressive symptoms? So if it's going against their premorbid beliefs, you got to think about what could be contributing to make them change their decision. So, and in this case, it was a lot of that dysphoria, the difficulty weighing the consequences for and against, having those delusions, all those things really affected and really changed her premorbid wishes to make her want to pursue an abortion. So depression, they're arguing, really can affect autonomy, like it is clearly evident in this case. She wasn't able to have capacity while she was experiencing those very depressive symptoms, but once they treated her, she was able to state that her wishes went toward that premorbid decision-making, the premorbid ethics that or beliefs that she had before she became ill. So again, they make the point at the end too of just about ambivalence should not be, especially if it's there by itself, and all the other criterion, as I discussed, are really present, so they can understand the relevant information, they're appreciating the situation and all the consequences, and they can manipulate the information rationally. Ambivalence alone should definitely not be a reason to say that they are not, they do not have capacity. So in this case, I think what's important to note is that they were able to treat her depressive symptoms. The venlafaxine and the olanzapine really are what restored her capacity. Once those symptoms were more managed, she really did, her decision to not pursue the abortion really matched her original intent, which was to have a baby. And that, that was consistent, which is very important. And so in this case, they do make the point that, obviously they were trying to work against the clock, only a 5-day window to try to restore her capacity. And really that is very important to try to have as much time as possible as you can to restore that capacity. And that was really the most critical intervention that they did, was just, they determined initially she didn't have capacity, but that didn't mean they gave up. That didn't mean that they went to her husband and said, okay, what do you think we should do? they said, you know, let's try to make sure we can have her make the decision for herself. And I think, you know, this isn't explicitly written in this case, but doing that, like taking that time, you know, having her meet with OB, having her symptoms abate is so important because, you know, at the end of the day, they were able to say, hey, this was your decision. You know, you came to this on your own, you know, and look at how beautifully, you know, the story went. She basically, you know, ended up being discharged. She didn't have the abortion. She remitted and stayed remitted, you know, up until the end of her pregnancy. She was happy to have her son and, you know, stayed well postpartum, stayed on the medication. And it's just a nice ending to what could have been a very sad story, you know, if they would have just said, okay, she doesn't have capacity, you know, husband, what do you want to do? He's ambivalent. You know, maybe he says, okay, no, maybe we're not ready for this child. I'm scared. How am I going to care for my wife and a newborn? You know, so this could have gone a very different way. And had she finally come out of that depression, she may have very much regretted what happened. So I think that that's kind of the final, I guess, take-home point that I'll mention, which again wasn't in their summary, but I think it's important to note.
Yeah, absolutely. That is, I think, such an interesting case. I think I may have actually presented this case at one of our, because this is from what, 2016, I
Yes, I
think?
believe so. Yep, January
Yeah,
2016.
yeah, I think I did present it. But I thought it was such an interesting case myself. And because I don't really see pregnant women at the VA very much on the medical floor. So, um, I feel like the case makes you really think about the tenets of capacity and ethics and also like issues with abortion and pregnancy, which are difficult and at times like people really have some ethical thoughts about those as well. Um, and just kind of what is the right way to treat a pregnant woman. And I do feel like you're right. They did due diligence in the case and I think did the right thing. So, um,
I just saw that one comment that you know, stopping the venlafaxine because of fears of
mm,
teratogenicity was a big mistake.
mhm,
You know, it's easy to say that in retrospect,
mhm,
but it's hard when you're actually counseling a woman about the risks.
mhm,
Those, you know, that discussion with moms who are planning to conceive is a tough one. You know, she didn't have that strong history of like multiple depressive episodes leading to hospitalization, lots of suicide attempts. You know, when I have a case like that, it's kind of easier to
mm,
sell that point of no, you need to stay on the medication
mhm,
because, you know, the risks of not taking it are you could really have a rapid
mhm,
decline. But when you have somebody who, you know, is high functioning, hasn't had any hospitalizations,
mm,
and you're telling them, you know, there's the short term or like the risks of the baby are not very high, but we don't know a lot of long term risks. You know, are there going to be more behavioral, more IQ things later on in life? You know, we don't have really long term studies, so I think that's a harder sell. Yes, you know, I would definitely advocate most of my patients stay on their medications when they become pregnant, but you know, it's not like I can, you know, tell them you need to do this.
mhm,
It's up to them to decide, and I'm just here
mhm.
to help guide them and help them make the best decision for them. But you know, I don't know if anything would have been different. You know, I'm sure this psychiatrist counseled her, and clearly that's probably why she
Mhm.
didn't take the medication. Um, and it's a hard thing. You know, like I
It's
do this all
tough
the time.
too. Yeah. No, and it's tough too when the women, let's say they stay on the medication and then their child later has like ADHD or some other,
Yep.
kind of soft issues. And then the mom blames herself. Like it
Right.
must have been the medication when
Exactly.
who knows what the reason for the ADHD or whatever was.
Right.
Or maybe it was multifactorial. So it's tough.
I see
There's,
somebody saying, yeah, she did have family history of depression. That's true
Mhm.
too. But you
Yeah.
know, even with that, even, you know, I mean, I can literally have like two columns, you know, here are your
Mm,
risks and here are the risks of the medication. And, you know, unless there's like really strong evidence saying, you know, that they might be at risk to either relapse on drugs or
mhm,
you know, have more suicide attempts, a lot of women decide not to do it. And, you know, it's actually, and this is one thing that I didn't bring up with this case, but, you know, let's say her doctor had said, okay, let's have you do the first, you know, trimester and then we'll restart you, you know, because a lot of women worry about that teratogenic effect in the first trimester. Maybe that's something that she would have agreed to do. I don't know. You know, maybe it would have been too late anyway, but, you know, that's something that could be explored some more too. Or maybe they did talk about it and she just didn't want to do it at all during the pregnancy. But some women elect to do that.
Yeah. No, and I'll say too, I think also, unless you've been trained in women's mental health, some of the things that we're learning about medications and pregnancy, I feel like have been much more prominent in the last couple of years, and maybe in 2014, 2015, when this case happened, it wasn't quite as known, and the person treating her wasn't as, you know, well versed in women's mental health, and so maybe her psychiatrist did recommend for her to stop it at the time.
Yeah,
like, we don't really know.
That's really true. Yeah, we don't know.
Yeah, I don't know. It's always tough either way. So
Yeah.
but yeah,
And I
this is
think that going along with that tenet, like they said in the article about autonomy, you know, you just want to let them make the best decision for them, having all the relevant facts. So I think that's the best we can do.
Yeah. Well, thank you. I don't know if there's any other questions. It sounds like just kind of some comments affirming some of the things you were saying. The treatment, I was thinking that ECT sounded like the perfect treatment for her, but ECT, I guess, is like abortion because you can't have a surrogate sign for that either, at least in Illinois, right?
So, you know, that's a good question. I don't know if I've ever actually had that particular scenario.
Well, maybe not with a pregnant patient, but just in general, right?
Okay.
So I think it has to be court ordered.
Yeah, I think you're right.
To forcibly do it.
Yep, I think you're right. But yeah, if she had agreed to it, I mean, that could have been, especially with the 5-day window, you know,
right,
a fast way to get her remitted. Yeah. It's definitely a good thought.
Yeah. But yeah, I feel like it would have been hard to predict psychosis in this patient. It's so rare, right? Psychosis
It is.
in pregnancy. So
especially in pregnancy. Yeah, definitely.
So I don't know who knows who it's going to hit. And then one more question. What if she was on lithium for bipolar disorder and a court-ordered involuntary ECT? Yes, court-ordered can be done sometimes, but I bet a judge would be hard-pressed in this case.
Yeah.
So
I wonder how that would have gone. You know, if she was refusing medication, or if she was determined not to have capacity to agree to medication, you know, would a judge have forced ECT? That, you know, given how severe she was, I think it probably could have been something that might have happened. Now, if she was on lithium for bipolar, I guess I'm not sure if the question is, are there risks associated with taking it in pregnancy, or is it that capacity to agree to lithium in pregnancy? I wonder if, Anand, you can elaborate a little bit more. I want to make sure I answer your specific question.
Well, give it like a moment, but
sure.
But yeah, there are a lot of what ifs and different medications. I think.
Oh, risks of lithium. Yeah. So I guess it depends on when are you counseling the patient. So if it's preconception, you know, there's a lot to consider. I think a lot of women decide not to continue lithium during the pregnancy unless their symptoms were so severe or lithium was the only medication that ever worked for them. Those are like the only scenarios where I've ever successfully had a patient decide to continue. Yeah, lithium and Epstein's anomaly. So it's a lot lower, the risk, than we originally thought. So usually I do mention it as a potential risk. Still, I would definitely make sure that it's included in my discussion of risks and benefits, but I also put it in perspective and let patients know that it's really order of magnitude, like only very slightly higher than the risk to the general population of Epstein's anomaly. And, if they were absolutely adamant that they didn't want to have that particular adverse event, then I would, or congenital malformation, I would suggest that they either, if they could, which again, this would be patient or case specific, abstain from lithium for until the heart's fully developed and then restart, or just switch to an atypical antipsychotic or something else that we think would be more effective, and just continue with that. I would hesitate to say, do two different medications because you want to lower the risks or lower the exposures as much as possible. So the less exposures, the better. And each medication is an exposure, and the illness itself, if she was to relapse, is also an exposure. So we try to keep them as healthy as possible, and also limit the amount of medications that the baby is exposed to. So, I definitely would still talk to my patients about it and let them know that it's a potential risk, but also that we would be monitoring for it. So I always recommend a level 2 ultrasound for all moms that decide to stay on lithium, so that we know if there's any cardiac malformation and we can address it early. Hopefully that answers his question.
Sounds like it. Okay, well, thank you, Lisette. Great case, great discussion. And Jessica, even with the best education, most psych diary? Maybe there's some autocorrect that I'm not picking up on. But yeah, this is a great case discussion. And, as we're wrapping up our journal club with the articles that we've done, we are, or at least I'm thinking about, where to take things next with either Facebook Live videos. I actually like tonight's discussion, and some of the articles have been good as well, like some of the review articles, but it's nice to have a case that we can discuss and then people can chime in on. So that would be a thought. I don't think I can keep up twice a week anymore, but maybe like once a month we could do something like that. So that's one option. And I am also working on planning some events in the next month or so, and we will just keep an eye out for that. So if you're not on our mailing list, just send me an email at psychiatrynetwork@gmail.com. I'm using it sparingly, so I'm not spamming anybody, but at least that way you can stay up to date on events. And then finally, the last event I want to mention is the Women's Psychiatry Conference. We're having our second one this year in September. Lisette was actually one of our speakers last year and attendees, and did a mental health, women's mental health topic, which was awesome. And I don't know, Lisette, if you have any feedback about the conference or want to tell people kind of what your experience was.
It's a great conference. Please come. I'm coming again this year, just as a attendee, and probably get to enjoy it even more because I'll be less nervous. I won't have to present. But it was phenomenal. It was just a perfect mix of, academic topics and fun things to do, and, really just meeting other colleagues from around the country, people who are, really interested in just CME, plus having, fun nights out to dinner with each other, and just, learning about the city you're in. So I think it's a great mix of business and pleasure. So hopefully more people will decide to come.
Yeah, we did just fill up our room block, but I am in the process of adding about 10 more rooms. So that way we can, maybe 5 singles and 5 doubles is what I'm looking at. And that way, if anybody still wants to attend, you're like able to still sign up. Just go to psychiatrynetwork.etc.com and you can find the information there. And yeah, hi Audra. Yes, we're excited to have you come too. So, and yeah, this year's topics, I don't have any of the same speakers from last year as this year. I loved all our speakers, but for anybody who's repeating the conference, I want them to have a new experience each year. So we're doing different topics. This year, we're focusing on a combination of different areas of psychiatry, like sports psychiatry, correctional psychiatry, as well as some things like Instagram for your practice, or Instagram is for professional use. We're going to have a workshop on that, a couple of telepsych talks, and a legal talk on an attorney on contract negotiation, whether it's a new contract or an old contract that you want to update. So it's going to be awesome. So I hope, if you're interested, just send me an email or send me a message. And if you have any questions, I'm happy to answer them. So,
And
all right,
Christina
guys.
and Adrian did an awesome job, and you would never
Oh.
know that it was their first year doing it last year. So I just got to give you guys a hand, because it was amazing, and I'm sure
Thanks.
this year will be
Yeah.
even better. So
Yeah, no, it was definitely like a busy, kind of stressful, but really fun few days, like getting to meet so many different people from the groups, names that I've seen so many times, and getting to meet them in person was awesome. So I'm looking forward to it again. Yeah, so we'll see you guys. Yeah, and so I guess I will see you guys hopefully in the next few weeks or month or so. We'll figure out something else to do for a fun Facebook Live video. All right, have a good night, and thank you, Lisette.
no problem. Good night.
Bye.